The problem with hyperglycemia in type 1 diabetes is it can be much more complicated to deal with than hypoglycemia. High glucose levels are common, especially in those with diabetes who are very unwell, and they can be managed safely. However, a person with type 1 diabetes has a 1 in 25 chance of going into DKA as a result of mismanagement whilst in hospital. Most people can be safely supported to avoid hypers by temporarily increasing their insulin, so long as it's done in conjunction with a proper assessment of the patient. It's very tempting to give one-off doses of insulin without a proper assessment in response to high blood glucose levels. But we're making these films because this action can sometimes mask more serious symptoms, and a decision made last thing at night without adequate consideration could lead to harm. On the orthopaedic ward, Mr. Kaminsky has a glucose level of 15, pain from a broken leg and type 1 diabetes. He had a hypo this morning, and that treatment might have pushed up his blood glucose levels. The team consider his situation, test for ketones, check what insulin he has on board, and give him a correction dose of rapid-acting insulin. They look at reducing his regular insulin doses to prevent a hypo happening again tomorrow morning. They'll check him every couple of hours and talk to the diabetes team in the morning. Across the corridor, Mrs. Kumar also has type 1 diabetes. She too had a hypo which was treated, but her morning insulin was forgotten. She's now very unwell and vomiting. Blood ketones are 4. The team diagnose a pneumonia and DKA, and appropriate treatment is started, including antibiotics and a fixed-rate insulin infusion. It's important that blood glucose and ketone levels are monitored regularly to ensure you're in control. The team continue to give her long-acting basal insulin because that will help with the transition back to normal insulin use. Something to be done with the help of the diabetes team. A reminder about ketones. Check them when glucose levels are at 14 or above, earlier if someone's unwell. Less than 0.6, they're normal. 0.6 to 3, give extra insulin and hydration. Over 3, treat as DKA. Keep an eye out if nasogastric feeding. If the patient doesn't have enough insulin on board, it can push up blood glucose and cause hyperglycemia. If there's a blockage or feeding stops for more than 2 hours and insulin has been administered, it can go the other way and cause hypoglycemia. Number 1, identify and treat the underlying cause of the high blood glucose levels. Check for blood ketones and follow DKA guidance if required. Rule out insulin pump failure. Review medication and consider alteration of regular doses to prevent it happening again. Consider use of variable rate intravenous insulin infusion in an unwell patient. And interact with the local diabetes team at the next available opportunity. Always make sure you undertake a proper review of the patient. Without doing this, you'll not be able to make an appropriate treatment plan. Assess their ability to self-manage and review their insulin use. Always remember that the symptoms might be the first presentation of someone with type 1 or type 2 diabetes. There's information and guidance for insulin doses, ketone management, and intravenous insulin infusions available on the wards. If you're not sure, ask.